Welcome to All Things Cardio-Oncology. My name is Steve Caselli. I'm the Executive Director of ICOS. And in this podcast, you'll hear from a diverse representation from our community. We want you to be both informed and inspired by their stories and experiences, and we're so glad that you've joined us today. The following episode was recorded live and outside, so there may be a little bit of background noise, but other than that, we know you're going to enjoy this recording. This is Steve Caselli. I am at the ACC meeting in Atlanta on a beautiful sunny afternoon, and I'm here with my colleague Dan Lenahan and our friend Dr. Diego Sadler. And many of you who listen to this podcast have probably heard Diego's name in many different contexts, but one of the things we want to talk to him about today is the GCOR Registry, which is a registry that he has spearheaded. So Diego, I wonder if you could start by just, for those who don't even know what the GCOR Registry is, just describe what that is and maybe a little bit about how that came about.
Sure. Well, yeah, thank you. Thank you, Stephen, and thank you, Dan. Yes, so GCOR is the Global Cardio-Oncology Registry. This is an initiative that we started working a couple of years ago as a collaborative effort with multiple colleagues and friends from all over the place, from both academic and community centers, and through many of the work groups from ICOS and also from the American College of Cardiology, American Association, as well as with colleagues in Europe, Asia, and different parts of the world. GCOR is a global registry with the goals of looking at the prevalence and incidence of cardiovascular toxicity or cardiovascular disease in cancer patients in cardio-oncology centers and practices, and look at it both in academic and community hospitals, and try to obtain a global database to validate some risk scores, looking at utilization rates of some of our common modalities, like imaging modalities and biomarkers in different geographic areas, in different countries, and in different geographic areas in different countries, and also in different socioeconomic environments. So in addition to all the clinical data, we're looking at clinical imaging, biomarkers, but also socioeconomic data and some of the socioeconomic factors that may be reflected not only by access to care, but maybe different utilization rate of imaging and biomarkers and certain specific cancer drugs or targeted therapies in different populations, and look at the impact on outcomes. So we started with a survey that we did to people who had expressed interest, and that survey has been going on over time, and asked the centers, so what are the priorities in your cardio-oncology program? What do you guys see? What do you need? What are the main areas of patients you're taking care of that we may want to be reflected in a global database? And the three groups that emerged were, number one, breast cancer, number two, hematological malignancies, and we established the three priorities as lymphomas, leukemias, and multiple myeloma as the three global categories. And the third group is immunotherapies, patients with, so the first two are based on the cancer type, the third one on treatment. So the third pillar is patients treated with immune checkpoint inhibitors, and where we think is a great opportunity looking at the global scale, obviously not only of checkpoint inhibitor myocarditis, which requires a lot of granular information, has been very well studied with very sophisticated registries both in the US and abroad, but to have an incidence of global prevalence of cardiovascular disease and accelerated atherosclerosis and all the phenotypes of cardiovascular disease in this population in different parts. So the way we structured and started this is, first we started with a US pilot. We have a scientific committee with people from, I would say many, if not most, are ICOS members, but we have people from all over the place, and from both, we wanted to have representation both from academic and community centers, US, Europe, Asia, Australia, and South America. So as per now, we have 150 sites in 35 countries, and nowadays includes every continent. We're happy to report that we have 3 or 4 sites from Africa, from Uganda and Tanzania, who've signed up and want to be part of this. But as per today, we have not launched the international part yet. I'm going to go over that in a minute. So we started about a little over a year ago the U.S. pilot study to make sure that the concept was legitimate, it could be done, it was feasible. We have the Cleveland Clinic housing the database, and we have the support of their C5 research division and data management group. And we constructed the initial database with the ECRFs that we got initially, also in combination with one of our European partners, Dr. Teskey in the Netherlands. And we adjusted for the GCOR needs, added all the socioeconomic and some additional imaging labs and biomarkers information, and we started that. So we started enrolling centers little by little. Each center to be enrolled after accepting that, they need to get a data user agreement and IRB approval that may or may not require consent. We leave that to each site as long as they have IRB approval. And then, as you know, or as you can imagine, getting agreements between hospitals takes time. So they started trickling in February or March of 2020. In March of 2023, and it's been a little over a year where centers have been active, and now we have up to 20 active sites. We enroll breast cancer patients only, and we demanded a new cancer consultations because we wanted to reflect contemporary cardio-oncology care. So people who've been in cardio-oncology clinic for 10 years were not eligible. Every consult after June 1st, 2022 became eligible, only new consults. And so far we have 530 patients enrolled, and we're following them prospectively. And
so Diego, not to cut you off there at all, but rather I'm just listening to what you're saying, and it's like it's kind of awe-inspiring. I mean, the amount of detail and effort that it's taken to get you where you're at is really incredible. I mean, that is just such an ambitious project. I mean, how did you get this done? This is crazy.
Yeah. First of all,
I know there was a lot of blood, sweat, and tears, but
it's
a
lot of work.
It's awesome.
Yeah. So. It's a lot of work. It's a lot of, as you know, there's always little barriers and steps to jump. But sometimes until you get the hospitals activated, and then once they get those two issues, also we do protocol training and database training. So from here we send them that for the PI and site coordinators that design. We send them a protocol, a few slides, they need to test that. After that, our data management sends them a link with a video where they get all the information about the database, and also it's a DDI, a dictionary with the definitions. And then they start enrolling. It goes to a cloud, to the RedCap cloud, and we're excited about this, but we know we're overdue to expand to our 3 platforms. So our goal for 2024, and we hope in the next couple of months, is to start enrolling the other 2 pillars, hematological malignancies and checkpoint inhibitor patients. And
so how do you deal with the different languages?
Couple of things. So I didn't get to the international part yet. So we're still in the U.S.
Okay,
and
that's fine. Even
of
just
course.
Doing it in the U.S. is pretty awe-inspiring. But you did say you have 35 different countries.
So this is just to summarize what's next for later this year for the international. And we'll first of all, with the language, we need to keep it simple. So everything is in English. All the investigators that have signed up speak English, and so the platform is in English. And I know that ideally we've had multiple institutions funding this and lots of money. We'd have a translation service we presented in 20 different languages, but we're not there. So our reality is our platform in English, and all the investigators that have a cardio-oncology program have English. So even though they interview their patients in the original language, then the data will be entered in that. So that will not be a barrier. So as we said, for the next phase, the international phase, our goal is to activate, and again, we have a census of 135 hospitals in 35 countries in every continent who have sent us demographics of what patients they see, if they have abilities to do imaging, biomarkers, what percentage of patients of them are of these three pillars, etc. So, as we were saying, it would be almost impossible, very difficult, to have data user agreements and legal agreements with 35 countries on each individual site. So, after talks with some of our research teams and with the RedCap Cloud platform that's hosting it, we came up with a solution that we're very enthusiastic about, and it's the system of silos. So a silo is a place where each country or region, we've got 10 silos planned, most of them include several countries, host their own data. So we will have a method with our research team supervised by RedCap Cloud where we'll transfer exactly the same ECRFs to these countries, right? And so we'll all be collecting exactly the same, but we will not host them. They will host them. So they're hosting it. We cannot see their data, so we don't need a data user agreement or IRBs. They will be in charge of doing that. So it'll be GCOR USA, GCOR Canada, GCOR Spain, GCOR Australia, et cetera, and as we don't want to have 35 silos because it would be too costly or too difficult to coordinate, we've established 10 silos. That's a preliminary idea. So, for instance, in Europe, we'll have one for Mediterranean Europe, one for Northern Europe, and one for non-EU countries that have different regulations. Then we have like 30 centers in South America. So the two top countries with lots of hospitals are Brazil and Argentina. So we'll have South America North led by Brazil and South America South led by Argentina. Will they coordinate that? So we've spoken with the leaders on that, and we know some people.
Well, all I'll say is that I think you must have a lot of phone calls.
Yes, a lot of phone calls.
And probably not all in English.
Right, a lot of emails. Right, in every different countries. But I want to say that even some of the countries and I would say most of the countries who say they want to pilot this initially are GCOR and ICOS leaders who we know they are very respected and leaders in the field who want to take over and lead their countries and have that. So it's important for us as a society to have people who are experts and we know they know how to run a registry or a database and do it well.
Yeah,
so,
I mean, I think this is where you definitely want to lean on your friends, and you've cultivated a lot of friends, so that's really to your credit on that. So I think one other main question, and you've probably answered this before, but how do you fit that into your day? All the stuff that you're talking about.
Yes.
So there are only 24 hours in a day, and most people do stuff during daylight hours. So how do you get this done?
Yes, it can be a little bit of a challenge, but I think that we've been able to fit it. So we enroll the patients during their regular clinical consults. So, and we just consent them at the end, since it's a minimum risk or no risk study because it's just entering de-identified data into a database with a lot of cardiac and oncology information. So it generally doesn't take much. We know now that probably entering a new patient takes about 30 minutes. A follow-up visit is about 10 minutes. And every center has become better as with everything as they do more. And our ask at the current time is to try each center to enroll at least 4 patients a month. So it could be an additional 2 or 3 hours a month for each site. And generally, we've been lucky that since these are all cardio-oncology programs, in addition to their PI, they generally, people are enthusiastic about being part of this, and some of the fellows, the residents, and some of the APPs are also part. So far it's worked out fine, but yeah, we understand that it can be a challenge.
No, this is really incredible. I mean, I applaud your efforts. There's so many times that we're talking about this general concept in all our various meetings or telephone calls or Zoom or webinars, whatever, where people say, oh, we need to have, some real life registry that actually is giving us a window into what happens in the world or in a particular practice. And to me, it sounds very much like what you're doing is trying to answer those questions. So it's really incredible. And I mean, wow, I don't know what to say. It's absolutely a labor of love, I can tell, obviously.
Yeah, thanks, Dan. Yeah, it's a lot of work, but again, I see this as a testament of what our cardio-oncology community has become. Because I always say, as you know, for me, and when I come to AC or we go to GCOS or we go to any of the meetings, it's like you see your cardio-oncology family. It's been all these people working this all these years, and everyone's been so supportive and went to it because we're all doing out of our good. So I think that, we all got inspired by people like you and Anna and all the people who started this, and we all, became involved and try to do our little contribution, and we'll see where we get.
Yeah, well, I would say more than a little contribution on your end, but we really appreciate all your effort, and any way that ICOS can help, make connections or help to try to come up with funding, anything that would be helpful, we want to do it. So thank you so much for what you're doing.
Well, thank you, Dan.
All right.
For more information about ICOS, you can go to ic-os.org, where you'll find more information about all of our programs, including our weekly webinars, our board certification exam, and other resources that we know you'll find helpful. Thanks for joining us today, and we hope to hear from you soon.